This is a recorded lecture on a concept of gas exchange, starting my content in Unit 1. So goals for this concept are to define and describe the concept, notice risk factors that impair gas exchange, recognize when the client has gas exchange compromise, and provide appropriate nursing and collaborative interventions for optimizing gas exchange. So collaborative interventions are going to include things from healthcare providers, ancillary services such as respiratory therapy, those kind of things. So definition, there's a process by which oxygen is transported to the cells and carbon dioxide leaves the cells. So there are some key terms that we're going to talk about here. So the first one being ischemia. So ischemia is an inadequate blood supply to an organ or part of the body. Most commonly when we think about ischemia, we think about myocardial infarction. That's when blood flow does not get to the heart and the heart muscle is damaged. Hypoxia is a partial lack of oxygen. This is one of the first signs that we see in people when they're hypoxic. You're going to see that restless behavior. Maybe they're a little bit more confused, or they are now confused and they were not before. Things to look for definitely are, let's get a pulse ox on them and see if their oxygen level has dropped. If they are hypoxic, they will show us signs and symptoms of that. Anoxia is total lack of oxygen to an area. When we think about this, we usually think about no blood flow and oxygen to the brain. If somebody has a traumatic brain injury, or if they have cardiopulmonary arrest and they don't have enough oxygen that goes into the brain and stays there, they will have what's called an anoxic event. The brain cannot store oxygen, nor can it store glucose, so it needs a never-ending supply of that in order to function. And diffusion is particles moving from an area of higher concentration to an area of lower concentration. So this is just a schematic showing. So the red is when we're nice and pink and we have lots of oxygen on board. So we have an optimal gas exchange. As we start to get impaired, maybe we're not breathing deep enough. Maybe we've got medication on board that is causing us to be more lethargic. We're not taking deep breaths. Our breathing is shallow and we're retaining CO2. We're going to see signs and symptoms of impaired gas exchange. Clients may get a little more blue. We might have circumoral cyanosis, which means bluish around the mouth. You may also see the earlobes get more blue. And that is a serious sign. That is central cyanosis. And if that means that we as nurses have missed the subtle peripheral cyanosis signs, such as dusky nail beds, increased work of breathing, maybe a little blueness around their mouth. So central cyanosis means really significant hemodynamic problems there. And then if we get down to the blue, that's absence of gas exchange. And of course, that means we don't have oxygen on board. We may not be breathing, and your patient is going to show you this, and they're going to be cyanotic or blue. So this is shows just what happens in the alveoli. So the alveoli is the little taskmaster in the lung. We have thousands and thousands and thousands of these. So what happens is the unoxygenated particles, or the hemoglobin and the red blood cells, come in through the pulmonary system, through the pulmonary artery in the heart. They travel to the lung. The circulation goes right by the alveoli, and because there is more oxygenation, more oxygen particles in the alveoli than there is in the bloodstream, diffusion takes place. Oxygen leaves the alveoli and goes to the red blood cell and out to the body, and the carbon dioxide leaves the unoxygenated blood cell and goes into the alveoli, and that is gas exchange. Skip that. So this is another picture just showing the process of gas exchange. So the atmospheric air, or what we call room air, that's 21% oxygen. So the medulla is the primary center of respiratory control. The main function is to send signals to the muscles that control respiration for breathing to occur. So the medulla tells the body we need to take a deep breath. If our thorax is intact and our diaphragm contracts, which is controlled by the phrenic nerve, then respirations will take place. So we pull room air, atmospheric air in through the nose, through the trachea, enters the bronchi, gets to the alveoli, and that's where the gas exchange occurs. And more towards the bottom, when you see cell metabolism, that's the reverse. The perfusion to transport hemoglobin from the cells. There's an exchange with carbon dioxide. Carbon dioxide is in the alveoli. It goes to the bronchi, to the trachea, through the nose, and we exhale that carbon dioxide into the atmosphere. So impairment of gas exchange occurs when this system is broken. There are lots of reasons why people have these types of issues. Whoops. Right. So ineffective ventilation, that can happen with COPD and asthma. I know my slide went ahead. I can't get it back. So anyway, or there's an overdose of meds that suppress the ventilatory drive. So some of those things would be narcotics, such as opioids. You know, if you're giving somebody an opioid for pain relief, such as morphine, we need to be sure that the respiratory rate is at least 12. If it's less than 12, then we really have to consider, you know, because we know that the respiration drive will also be reduced. So we have to make a good clinical judgment decision about that. Of course, paralytics, they use those in the OR. Sometimes we use those in ICU to paralyze the patient so we can take over all function for them with the mechanical ventilator for respiratory. Inadequate perfusion, that can be typically from a pulmonary emboli. It could be from a fat emboli. If somebody has a long bone fracture, such as a femur, they are at risk in the first 72 hours for having a fat emboli, which is really just a clump of fat that releases because of damage from the bone and the subcutaneous tissue and travels to the pulmonary system like a blood clot would. People who have pneumonia, of course, you're going to have a lot of infection, fluid, it could be blood, it could be anything that is causing that gas exchange not to occur. Pulmonary edema is the same. You get fluid backed up because the heart's not doing its job, the pulmonary system is compromised, and the patient will have fluid in their alveoli, and you will hear this as rails or crackles, and it sounds like Rice Krispies when somebody has rails or crackles, and that is fluid in their alveoli. Or if they have an airway obstruction, say they have aspirated chicken or aspirated something, a small child has swallowed a marble or something like that, that's going to impair both ventilation and perfusion because it's blocking that area. So the next slide, the consequence of that, if we are hypoxic or anoxic, then our tissues will be deprived of oxygen and they will soon die from lack of oxygen and blood flow. So individual risk factors for problems with gas exchange, age. As we age, there are changes to our lung tissue, to our compliance, to the alveoli undergo structural changes as well, muscles and bone. Normally your total lung capacity, which is how much air, the maximum amount of air that you can pull into your lungs, is 6 liters. As we get beyond 35, that total lung capacity incrementally decreases as we age. So we can't pull as much air as we once would. Smoking, of course, that damages circulation, that damages the alveoli, it damages the bronchi. People get structural changes and damage from, they get COPD, they have chronic bronchitis, they have emphysema, they have all those things that are also impairing gas exchange. Nicotine, of course, is what's in the cigarettes, and that is a vasoconstrictor, so that will also damage the blood flow and the oxygen carrying capacity of the red blood cells and the gas exchange at the alveolar level. So I pretty much talked about that. We've got COPD, cystic fibrosis. That's for a different issue. That has to do with mucus, related to, it's really related to a pancreatic enzyme defect, and heart failure, which would also leave blood or fluid backing up into the pulmonary system, and that will damage things as it goes on and is not relieved. Immunosuppression, as we get older, our immune system also begins to get tuckered out. We don't have all those nice B cells and that are looking for things that are abnormal, such as cancer cells or antigens or anything that is going to cause an infection in the body. The body loses its ability to recognize and then to get rid of those things. A reduced state of cognition, if your patient is really lethargic or obtunded, which is one step past lethargy, right before comatose, they may not be breathing well enough to have good gas exchange. Again, this could be from opioids. It could be from any kind of illegal street drugs that will cause a lethargic or an obtunded effect. It can also be from a traumatic brain injury or somebody who is hypoxic or anoxic. Prolonged immobility, we see this, of course, in the elderly for the most part, as they are lying or they're in bed, they're bedfast, they're lying on their backs, and everything is able to pool into the base of the lungs, and they can get atelectasis, which is really a collapse of the alveoli, which can be rectified by taking a nice deep breath or having albuterol inhalers, bronchodilators that will open those airways. This is one of the big reasons that the elderly end up with pneumonia in the hospital. If they've had a surgery, if you've had surgery, you know that it's painful. People don't really want to get up and move around because it is painful, but early ambulation and getting out of the bed into the chair, incentive spirometry, all of those things will help to prevent post-op pneumonia. So prolonged immobility is a big one in the generation and the genre of people that we're caring for. Elements of respiratory assessment, we're going to look at the past medical history, family history, any kind of medications that they're on, lifestyle behaviors, do they smoke, do they vape, any kind of those things. What is their occupation? We always have to consider that. Do they work in a coal mine? Do they work for a chemical company and they're exposed to things in the environment that are going to damage the respiratory function? Their social environment, problem-based history, and the examination, we're going to get vital signs, particularly the SpO2, which is the pulse oximetry, inspection of the chest. We're looking at the work of breathing. Are they breathing really fast? Are they not breathing fast enough? Are they dyspneic? Are they tachypneic? All of those things. Looking at their skin color, because again, that's going to tell us what their level of gas exchange is. If they're cyanotic, it's not so good. If they're warm and pink and talking to us, then we can hope that their oxygenation is where it needs to be. Looking at the thorax, is the chest rising and falling symmetrically? Do they have anything that is structurally wrong that is causing a problem with the rise and fall of the diaphragm? Also looking at their extremities, because we're looking for those early subtle signs of peripheral cyanosis in the lips, in the mucous membranes, in the nail beds. Is their skin cool? Are they sort of bluish and we see that they're not getting good oxygen delivery or good blood flow? And then, of course, auscultation of the lung sounds, listening for adventitious breath sounds, such as rhonchi, rales or crackles, wheezing, those kind of things. So common diagnostic tests for gas exchange, arterial blood gases, those are for people really who are on the ventilator, if they think that somebody is in DKA, which is diabetic ketoacidosis, they will get blood gases for that. So blood gases are going to tell us how much oxygen is on board and how much carbon dioxide is on board. So we're looking at also the pH. That's going to tell us if they're acidotic or if they're alkalotic, because we can really begin to focus on a system if we know that they're acidotic. So acidosis would be a pH less than 7.35. Alkalosis would be a pH greater than 7.45. So normal falls between 7.35 and 7.45. Looking at the complete blood count, we're really focusing in on hemoglobin, because hemoglobin carries the oxygen. It has the heme, it has the red blood cell. Looking for that because we can get a lot of gas exchange issues if we don't have enough red blood cells on board. Also looking at sputum, this will really tell us what kind of bacteria, fungus, parasite, whatever is growing in the person's lung that is causing the respiratory issues. And then biopsies can be used for if they think that someone has a malignancy. Go in and take a biopsy of the tissue and determine if they have some type of lung cancer. So radiology studies, you know, the most basic is the chest x-ray, and that's really going to show you kind of structurally what's going on. It's not as good, of course, as a CT, which is a CAT scan, or an MRI, but the chest x-ray can show if there's fluid there or if there's infiltrates. You'll see that on your chest x-rays. It really doesn't tell you what it is. It just says there's some kind of fluid here. It could be blood, it could be pneumonia, it could be fluid, it could be anything. So it's a baseline study. It also shows us if the patient has cardiomegaly, if the heart shadow is larger than it should be, but it's just a start. And then we move on to CAT scans, MRIs, and those kind of things when we really want to see, you know, what is going on with that patient, if they have a pneumonia, if they have a pneumothorax. We can also see a pneumothorax on a chest x-ray. So a VQ scan is something that is not common. It's not highly predictive of really anything, but they like to do those if they think that the patient has a blood clot in their lung or a pulmonary emboli is what it's called. So they're going to see a defect either in ventilation or perfusion. It is a test that is involved with a radioactive tracer that is either inhaled or injected in the nuclear medicine department, and they'll take pictures of the patient over time and see how that tracer is being diffused or not. A PET scan is also one that we mostly think about for people who have cancer. They're looking at something, they're looking for metastasis to other areas, or hotspots is kind of what lay people call it. So pulmonary function studies, we're looking at how much air can a patient pull in, what is their total vital capacity, what is their total lung capacity. They'll do those things mostly for COPDers to see how much damage they have in their lungs. And then endoscopy rather, sorry. That would be like a bronchoscopy. The doctor or the surgeon will go into the lung, and actually they can do biopsies through a bronchoscopy. They can lavage and remove a lot of fluid, and then most importantly they can visualize the lung tissue and see if something's going on with that. So primary prevention is going to be infection control, which will go back to the little old person who had surgery in their post-op, and we need to be sure that we're using good hand washing technique, that we're preventing sick people from coming into the hospital to visit them and sharing their bugs with them. Also be sure that they're getting the right antibiotics. So as nurses, we don't order antibiotics, but we do monitor cultures that come back, and we notify the healthcare provider. If the patient's sputum comes back growing MRSA and they are on Rocephin or ceftriaxone, Rocephin is a broad spectrum penicillin, but it's not going to do anything to treat MRSA. So we would notify the healthcare provider of that and make sure the patient is on the right antibiotic. Other things we do, preventing post-op complications, early ambulation, getting them out of bed and in the chair, getting them an incentive spirometer, and making sure that they try to use that at least 10 times See if they can pull air 10 times every hour. I would always tell my patients, just pick it up when a commercial is on and use it then. It really is a simple tool that can really do a lot of good and a long way to prevent post-op pneumonia. Smoking cessation, of course, that is a necessary part of this, so we can stop the damage to the heart, not the heart, to the lung. Also immunizations. The Pneumovac vaccine is the pneumonia vaccine that is given every 5 years, typically to people who are immunocompromised or people who are, I think, over 60. And it doesn't always prevent them from getting pneumonia, but it is certainly helpful. Just like the flu shot, doesn't always stop you from getting the flu every year if you happen to get a different bug that of the top 5 that was used to make the flu shot. So, but all of these things are, primary and also secondary prevention, which are important. Smoking cessation again. So pharmacotherapy types of medications. People who have COPD, asthma, they rely on bronchodilators. Particularly with asthma, they use albuterol, which is the only rescue medication out there. So this is a bronchodilator that is, of course, going to open up the airway so better gas exchange can occur. Other medications are steroids. We use a lot of those with people with gas exchange issues. They would take the bronchodilator inhaler first and then take the corticosteroid inhaler next, so you have more surface area for that corticosteroid to get into the bloodstream and do some good. Other things, cough suppressants, dextromethorphan, antibiotics, correct antibiotics, all of those things are helpful with problems with gas exchange. Nutrition therapy is also important. You'll see people who are COPDers, particularly in the end stage, it just takes everything they have just to breathe. So they always have poor nutrition because it just takes too much work. So if they have poor nutrition, they don't have good caloric intake, they don't have good carbs for fuel for their body, and they don't have, also more importantly, proteins to help them heal from anything that they're suffering from. So nutritional therapy is really important. Things that we can do to help that, of course, ask the person what they want to eat. If you don't like Brussels sprouts, then I wouldn't give them Brussels sprouts because they're probably not going to eat it. Things we can do, milkshakes. We can put protein powder in milkshakes. We can offer them 6 small meals a day because that's not quite as daunting as the big dinner tray that they get. And most of the elderly that we're caring for, they grew up with the Clean Plate Club. That means that you eat what's on your plate and you eat it all, because they come from Depression era, their parents were Depression era, and that was their family culture. Positioning is important, making sure they're sitting up at least 30 degrees or in a high Fowler's position. If they're lying on their back, lying on their side, more likely things are going to pool. They'll get atelectasis. They'll have reduced capacity to pull air, which also impairs their gas exchange. Chest physiotherapy and postural drainage are more things that are collaborative efforts. That is from respiratory therapy. They typically will come in and they'll give the bronchodilator to open things up, and sometimes they will put the patients in a semi kind of Trendelenburg position with their head down. So all of that stuff that they break away will travel into the main bronchus and the patient can cough that up. But they'll literally take their hands and cup and beat on the patient's back and their rib cage. They also have equipment that will do this. They can put a vest on somebody that will vibrate. They have piccolo little respiratory things that they can blow into and pull air into, and that will almost kind of rattle the cage of the lung system and break things loose. So really important part to get rid of all that junk in the lung. Oxygen therapy devices, of course, oxygen is a drug, so we should always have an order for that. As nurses, we do have some leeway and a little bit of, we can use our clinical judgment for which oxygen therapy device the patient needs. So with COPDers, we're looking at 3 3 to 4 is really the max that you want to give a COPD or oxygen, because they do rely on a hypoxic drive to breathe. And that means that their brain is so used to having so little oxygen that if we give them too much oxygen, then the medulla will say we don't need to breathe. So the patient will become lethargic as the CO2 level rises, the oxygen level is low, and the patient will fall into what we call CO2 narcosis, and they will go to sleep, and they will eventually quit breathing if we don't intervene. So you always want to start somebody, usually 2 liters. That's a nice place to start with anybody. If you have to look at, is this patient really a mouth breather? Because oxygen nasal cannula is really not going to help somebody too much that is a mouth breather. So as nurses, we can use our judgment and change that to a simple face mask. So the patient is getting more of the oxygen into their mouth and also into their nose. If we have a COPDer and they're already up to 4 liters of nasal cannula and their oxygen level is not where we want it to be, we can put the patient on a Veni mask. Veni masks, which is a Venturi mask, are really good for COPDers because you can give almost the same level of oxygen, maybe 40%, 50%, but it's very highly concentrated, and they get like the most bang for their buck with a Veni mask. They get the best oxygen that they can have without overrunning their drive to breathe. Other things too, 100% non-rebreather, that's really kind of an emergency thing, or sometimes end of life. It's a mask, a face mask with a reservoir. Things for nursing need to be sure that we don't let that bag twist because it needs to inflate all the way. We need to be careful with that with COPDers. We can also stop their drive to breathe with that. So mostly an emergency situation, your patient is really hypoxic and you're transferring them to ICU or CVICU, and you want them to have as much oxygen as they can have until you get them to that next level of acuity care. Airway suctioning, of course, you do not have to have an order to suction anybody's airway. This is sort of a lost art. Nurses don't do this as much on the med-surg floors as they probably should. Sometimes that's all you need to do is suction somebody and get some of that junk out. Or if you're suctioning, down their nose, nasopharyngally, which you will learn how to do in this semester, it also stimulates them to cough, sometimes gag, but it stimulates them to cough, and it helps to clear their own airway. So mechanical intubation, with endotracheal tubes, we have oral endotracheal tubes and nasal endotracheal tubes. 9 times out of 10, somebody gets an oral tube. That's what you see on TV. It's the tube hanging out of the mouth, hooked to the ventilator, lots of tubing. We do have 24-hour closed suctioning systems that we use with people who are intubated. It is a sterile system, and we can intubate them without opening anything and breaking the sterile field. And it's a good way to suction somebody and prevent infection. Of course, tracheostomy tubes, that is a more permanent airway. An endotracheal tube is a temporary airway. People typically, before COVID, would only be intubated orally for 14 days because it could cause necrosis to the vocal cords. It can cause a tracheal erosion. So we try to get people off the ventilator before that, or they would do a tracheostomy, which is an artificial opening into the trachea, and we put a stoma there. And also it's a good way to also suction somebody, and it's also for those people who need more time. They also need to be on the ventilator, but they can't tolerate the endotracheal tube anymore. We're seeing that much more common now with COVID. People are getting trached and feeding tubes much earlier than they used to. And chest tube management, people that have a spontaneous pneumothorax, which is going to be a collapse of the lung from air typically, they would get like an upper chest tube, something really high up in the apex, because that's going to be for air management. If they have a lung collapse because of atelectasis, or they have a pleural effusion, which means there's some kind of fluid in pleural space that doesn't belong there, they will get a lower chest tube, and that's more to drain fluid out of that area to keep their airways open and have good lung expansion.